return on your investment. Thank you.
Okay, thank you. We're running over, so thank you very much, and I hope this never happens to you.
Deborah, thank you. That was a very sobering talk. Okay, and now Dr. Sam Lamb from Plano, Texas is going to come and talk to us about the Asian eyelid.
Thanks, Bob. Okay, this is a talk not just for people that are interested in doing Asian blepharoplasty, but for all of you who may encounter an Asian coming to you at 55 years of age, 60 years of age, and you don't know what to do. So even if you don't do an Asian blepharoplasty, this is going to keep you out of trouble. And so the first half of the lecture is just sort of the biomechanics of how to do Asian blepharoplasty in my experience. And the last half is an algorithm of how to deal with the aging Asian eyelid. So, you know, we first have to define what beauty is in the Asian. And I think there's a confluence of beauty today in both the West and the East. In other words, fuller eyes, lower creases, and not that skeletonized look that was typically very much in vogue for white individuals or non-ethnic individuals. But now there's, I think, across the board, a fullness is there because we're starting to recognize how much volume is important, as you've heard throughout this entire meeting. But what do you do with this person coming to you on the right who's a little bit more mature, some early signs of aging? Do you go ahead and just take some skin away? Do you go ahead and do a brow lift? Do you put fat grafting in? Can you do, you know, if you don't do an Asian blepharoplasty, what do you do for that individual? So I'm going to give you an algorithm to keep you out of trouble in the last half of this lecture. So first we have to understand some basic anatomy, and this is all it is. This pseudotosis is essentially a loss of, it's the fat, the postseptal fat diving down all the way to the edge of the ciliary margin, making the eyelid look puffy and lower and smaller in palpebral fissure. And you'll see that it's not an all or none proposition. In other words, an Asian may have a partial crease on one side, a full crease on the other side, a partial full crease on the other side. And you have to take a look at this, and so you may see that there's asymmetry there where the person has a smaller eyelid aperture on one side, and that's usually correlating to the side that has a less of a marked crease. So correcting pseudotosis, in other words, just having a weaker crease on one side, is actually relatively easy to do by doing an Asian blepharoplasty, whereas fixing true ptosis is not what this lecture is all about. So the other thing to understand beyond this is this crease height. We've really moved away from the occidental or overly excavated look, as I alluded to earlier. So large folds. This is from my mentor, John McCurdy, out of Hawaii, who's now passed on. But larger and medium folds, I rarely do medium folds. I never do larger folds. And I think one thing you have to be is have some artistic integrity of what looks natural. So I don't offer my patients every option in the book. Even if it's going to make them look weird or unnatural, I don't give them that option. So you either get a small crease if you want something very conservative, or a medium crease, which is only, in terms of visibility of the pretarsal skin, is just maybe 2 millimeters or so, very, very small amount. So we're talking about a fraction of a millimeter to a little higher than that. The top one would be a small crease with what's called an inside fold. In other words, it's ending lateral to the medial canthus, and then with a slight oval shape. In other words, a little flare, and that closed portion typically goes along with an oval shape. The bottom one is more of a medium crease that is more parallel and with an open medial aspect. So usually, again, closed goes with an oval, and a parallel typically goes with an open formation. This is just showing you two heights. The basic technique starts with, very simply, use the fine end of a gentian violet marking pen. Now, before this, I actually had the patient with topical BLT or topical numbing products for about 45 minutes. I don't include it, and that really helps out a lot. I do give them a little bit of IV sedation, a little versafentanil, just to kick them through the first 20 minutes of the operation. It makes the anxiety less. But I do have to have them awake for the part that I'm actually doing the having them open and close their eyes. So it just makes things a little bit easier. It makes them less anxious. But I always measure with with my dominant hand, I'm retracting the skin until the eyelashes are perpendicular. Then I make my measurements. The measurements for a low crease are around 6 to 7 millimeters from the ciliary margin, and I take about 2 or 3 millimeters of skin above that. All depends on how thick the skin is and what I'm trying to achieve. That's just a range. I sometimes take out 4 or 5 millimeters of skin as well. And after you've marked it there, you want to finish off the shape. This is a very conservative, not much of an oval shape. It's sort of in between oval and parallel, but it's going in is an inside fold. In other words, ending lateral to the medial canthus. So it's not going medial to the lateral to the medial canthus. And then with the skin pulling back, you can see the shape that I've designed. And that's how you design it, is with the skin retracted. Then I put some betadine. I place little aliquots, so I don't try to thread the lidocaine through the skin because it can cause ecchymosis. And once you get ecchymosis, it makes things much harder for you to read symmetry. So I'm using 1 cc of lidocaine mixed 50-50 with lidocaine and marcaine, and I just raise little blebs, and I just squeeze it with my fingers along the way, so it distributes the anesthetic along the total distance. I use no more than 1.5 cc's per side, and that way I keep the edema less, and I can read the symmetry a little bit better. I make the incision with a number 15 blade, and I'm going very superficially, just scoring through the skin, so that there's these vascular arcades that run perpendicular to the wound edge, and so I want to capture these before I actually transect them. So I'm just going on both sides of the little skin paddle. I'm going to remove, and I'm just cauterizing that along the way. Then what I do is, with my assistant, I always have my assistant retracting with 2 fingers here, so it gives me a little bit better visibility of the wound edge as I'm working, or the expanse of it. I just have her hold up, and I just remove this pretarsal tissue. It gives me a few benefits. Number one, it debulks the pretarsal tissue so it doesn't look so full. And then also what it does, it gives me faster access to the post-septal tissues where I'm going to put the suspension suture. And also what it does, it gives me a very good access right where my levator adhesion suture is going to be, which is along the inferior aspect of the wound. Then what I do is I say 4 fingers, and what happens is my assistant ballots the globe down so that I can actually start to see the herniation of the fat. And then this is actually after I made the fenestration. A small fenestration through the area I see. Typically about 1/3 along the inferior aspect of the wound, in other words, toward the bottom edge, and about 2/3 lateral. So I'm not all the way lateral, but I'm just over midline, lateral to the midline where I'm making this fenestration. Once you see fat, then you're safe. So that's why I'm having my staff help me blot the fat so that I can find the fat. By finding the fat, it allows me to ensure that I'm not going to injure the levator underneath, which is obviously the thing you don't want to do. And after you found the fat, and this is one caution, is if you're dealing with someone 40 or 50 or 60 years old, they're going to have a lot less fat. So you have to take this part of the procedure a little bit more slowly and make sure you've recognized and seen that fat. Then I just take a mosquito, I tent up, looking at the fat below me, and below the fat, the levator complex. And this is just going laterally with it. And then because there's a little bit of orbicularis still there, I do cauterize a little bit so I don't get bleeding. And then I just transect that with a pair of scissors. And I go that all along the distance from one side to the other. And it's usually toward the inferior aspect of that wound. And then I don't remove a lot of fat. I would say I remove fat in about 5% to 10% of cases. It's more prevalent in the Korean ethnicity, where they may have a more exuberance of fat. When I remove fat is if I feel that fat, especially laterally, is going to compromise my levator adhesion, then I'll take a little bit of fat. Not much, just a tiny bit. Majority of patients, I don't take out fat because it doesn't get in the way. And also, I'm really worried that over time they're going to become skeletonized and not look so good by the time they hit 30 or 40, for these younger patients I work on. So and especially an older patient, I almost never remove fat because they're already skeletonized and they probably need fat in their eyelid. So if you feel like, hey, they have too much fat, that's the reason why their eye is so small looking. That's not correct. It's, as I explained earlier with the anatomic slide, the reason is the fat is sliding down over the levator because there's no adhesion to it. So that's a pseudotosis, and a fuller eyelid does not need to have the fat actually resected. You can just migrate it up, put your adhesion below that, and it works extremely well. So I rarely remove fat. And if you're going to put a little lidocaine in the post-septal tissues, I just use plain lidocaine, so there's no epinephrine in the post-septal tissue. And it's really, really important to put a drop in there. Do not let it touch the levator. You can have levator anesthesia, where it's actually then the levator doesn't work on that side. So you've got to be really, really careful. That's why once the anesthetic is in, I work in a very quick pace because I want to be done with the procedure in about 50 minutes, all in. and that way I don't have to put more anesthetic in. The more anesthetic you put on one side, you don't want to get it post-septally, because if it drips on the levator, they have levator dysfunction. It makes it very hard to read symmetry. And secondly, you're going to have some symmetry issues. So if I put in an extra 0.1 cc's in the medial aspect, inferior part of the wound on the left, I'll do the same on the other side to maintain my ability to read symmetry. I use a 5/0 nylon suture. I just run it through the inferior aspect of the skin through and through. Then I run it parallel along the inferior wound edge, just through the pretarsal tissues. Really, I grab the levator. I find that it's far easier, and I get more tenacious hold on a levator bite than a tarsal bite. And then I come up and run it through superiorly through the top wound, and then I just tie it down and look for the degree of eversion of the eyelashes. I want them to be about perpendicular. The crease will look way too high, okay, on the table. Do not be alarmed by that. Because of edema, and it's just not going to look normal. So if you're worried about it looking fake at the time of the procedure, that's normal. You don't want the crease very, very small. It will look too high. The way that I've tried dissolvable sutures, so dissolvable fixation sutures, hopefully that will create a little bit more durability, but the crease actually looked too deep. So I really like to have levator fixation sutures that come out at 7 days. So the way I do it now, I put in a 5/0 nylon on one side, I go to the other side, put a 5/0 nylon, so I put it right in the middle of the wound. Put a 5/0 on each side, look for symmetry. And to minimize ecchymosis, if there's any bleeding that starts from when the suture goes through, even after I've just passed the suture, I immediately have my assistant hold pressure and wait about 2 minutes before I continue. And right when I've tied down and cut that suture, she holds pressure on that eyelid as I'm working on the other side. And then as I cut that one, I look for symmetry, she holds pressure, goes back and forth. That way it minimizes ecchymosis and inability to read symmetry. I put the midline ones going back and forth. Then I look at that, I break the lateral half of the wound and put one in between there. And then I do the same thing on the other side. And then I go back and put a suture in the medial side between the midline and the medial aspect. And then I break those in halves again. I just go back and forth. So I wind up putting about 8 sutures a side. Sometimes one side may need 9, or one side may need 8. Doesn't really matter, and I'm always looking for symmetry as I proceed. And then I just close the wound with a running 7/0 nylon. I do put a topical anesthetic on the patient afterwards at a week when I take out sutures, so they don't feel very much, and I take all the sutures out myself. I've had a nurse cause a dehiscence in my levator adhesion by aggressive removal, so I put on loops. I use very tiny little scissors that are curved. That's a good pearl for anyone taking sutures out for whatever reason. Tiny little curved sutures, and I can just clip it in very easily. If you take large scissors, my scissors to cut and remove sutures are actually far smaller and finer than the ones I used intraoperatively. So it's a pearl to use really tiny scissors to remove. They're like little iris type things with a little Castro Viejo type handles. Very, very, very tiny curved removal scissors. So this is an example of a patient about 2 weeks out in the middle, and then this is about 6 months out postoperatively in the bottom one. Edema does continue to resolve. You can almost see, this is a 1 week out on the middle slide, and the bottom was about 7 months out. You can still see a little bit of pretarsal edema even at 7 months in the bottom image, and that continues to clear. The top image is a good example of the pseudotosis. You can see the side that has a less of a defined crease looks smaller, and that's very typical. So oftentimes it's relatively easy to improve symmetry in a patient that has pre-existing asymmetry due to this pseudotosis. Clearly, if they have true ptosis, unless you do some kind of levator treatment, you're not going to get that improvement. I don't do any levator treatments. This is showing you a year out from this, and again, this is showing you asymmetry preoperatively that's become more symmetric simply because of the pseudotosis that is present. And this is, all these are very low creases. Very, very natural. I prefer to have an inside fold with a slight flare. I think it's the best combination in terms of getting a very, very, very natural look. Some of the pearls in the postoperative setting to minimize the long recovery time, because a full incision technique is my preferred method. It gives me a predictable, durable result that's good in young and old, and it gives me a result where I can actually shape the eyelid and remove fat if need be. Whereas I can't do that with partial incisions, I can't do that with suture techniques. And suture techniques have such a high failure rate that I don't even bother. And I initially did partial techniques, and I really didn't like them. And the biggest problem with them is they actually had more scarring. And the reason partial incisions have more scarring is that when you make an abbreviated incision, you can see the terminus on either side, the one side or the other. So you need, when I make a full incision, the incision is seamless. It goes away. You don't see it. But if you make abbreviated incisions, they actually look a little bit puckered and weird. Plus, they don't hold well, because you need to put in a lasting suture, one that is indwelling, like a nylon, a tiny nylon, and that becomes problematic with synthetic material that's there long term. They can spit out, they can get infected, and it's just, I really have migrated to the full incision. Of course, the biggest negative is the protracted edema, as you can see in the photos, but I think it gives me the best result. So this is the what I go to in my practice. So what do we do? This is the second half of the lecture, is what do you do when you have a patient coming to your office and you don't do Asian blepharoplasty, and you're wondering, what should I do in this situation? Should I go ahead and just take some skin away? And of course, a large part of this, my algorithm is developed through my errors. And so the more errors I've created, the more I've learned, and I've come up with something to keep you out of trouble. So I've divided it simply into 3 types of Asian eyelids. One is a person that is born with a natural crease, one that is not born with a crease, and one that had a surgical crease made in the past. And if you break it down into those 3 categories, then you can think about how you're going to approach this patient. This is a patient that was born with a crease, and this is in the old days when I did more brow lifts. I took skin away and lifted the brows, and the crease is too high. I think the crease is too high for her. This is not as good a look for an Asian. And so how do I make it, what's my algorithm if I have a patient coming to me and they already have a natural crease, a well-defined one? Remember what I said, in Asian eyelids, it's not all or none. It's not like they either have a crease or they don't have a crease. So if someone has, let's say 90+%, they pretty much have a well-defined crease, then you can lump them in the category of non-Asians. In other words, okay, they have a crease. You can just take skin away. But when do you take skin away? What do you do with this situation? So what I do is, the biggest thing, remember, is that on an Asian, you don't want to have a high crease. If you have a very high excavated and elevated crease, they don't look natural. So if the I'm going to show you some examples in a moment after I go through this algorithm. If they have, the skin is sitting at the ciliary margin, in other words, it's really redundant, almost hanging on the eyelashes, I will take some skin away. But I almost always, whether it's a white person or a non-Asian or Asian person, I will almost always add volume, because I'm a big periorbital volume person. I don't believe that just removing skin in the majority of patients works, whether it's Asian or not. So and why putting that volume is so important? Because once you've taken skin away, it does migrate the crease up. So you don't, to keep the crease in good position and low, adding volume will work, whether it's using synthetic fillers like hyaluronic acid or using fat grafting. That's really your judgment, your skill sets, and consultation with the patient. But I really believe volume is an integral component to the whole process. So again, if the person comes in with a natural crease and it's pretty well defined, I will only take out skin if the skin is close to the ciliary margin, and I almost always add some kind of volume. And if not, they don't want the skin removal. A lot of times adding a little volume is sufficient, whether it's fillers or fat, to get them there. So category 2, a patient that comes to me that's already had a surgical crease formed in the past. Well, again, this is another one of my errors. I took away skin, just said, you know what, this is the old days, I took some skin away, took a transconj bleph, okay, that's wonderful. The problem with this is it re-exposes this bad work that was done many years ago. So essentially what happened was, she had the old style 1980s, maybe into the 1990s, of occidentalization, where they're going westernization, over exuberant removal of skin, where the brow tissues are now, brow skin is touching the eyelid skin. They're over removed. But what happens, the reason why the crease looks so small, is that over time, with deflation, dermatochalasis, and brow ptosis, then that skin, brow skin, hangs over the eyelid, and it makes them look like they just have a small little crease. So then you think, oh, that's just easy, I'm just taking some skin away. Problem with that is that you have more exposure of this thick brow skin that doesn't fold well, and the crease looks too high. So the trick with this is, if you're dealing with a patient with a previous surgery, ask them when they had it done, and then just lift their skin up and look at how much skin has been removed and where their natural crease position is. How do you fix this then? So in this situation, I would be very hesitant to remove skin. I would just add a little bit of volume. Fat grafting, fillers, again, I'm a big volume proponent. Well, you know, keep in mind, if you heard my talk about fat grafting yesterday, I'm not just this sort of monolithic singular individual seeing that everyone needs a fat graft or a filler. I don't put in the cheeks, I don't make people volumize here, but I really think in the periorbital region, in my experience, I really believe that this area almost always needs some level of volumization. If I do a transconch bleph, I'm adding fat grafting back. If I'm taking away skin from the upper eyelids, I'm adding some kind of volume back, whether it's fat or fillers or something. I'm really a big proponent of this. And so in this situation, if you, just to repeat, if this person's coming to you and she has had a previous blepharoplasty, find out when it was, what kind it was, and make a decision whether you can safely remove skin. Taking away skin won't cause the crease to go away. It's just the problem of re-exposing a bad result that it's hard to fix. So adding a little bit of volume back would be the way to help improve the situation, in my opinion. Then you've got the third category, someone that comes to you that they don't have a crease or very poorly defined crease. If you can see, this gentleman has barely a crease. I would say this is like a 5% crease or 10% crease, which means he has no crease. So this is the mistake I've made in the past. This result is not a mistake. This is just doing an Asian blepharoplasty on this gentleman. The mistake I made was trying to just take away a little bit of skin. If someone has a very poorly defined crease and you take away skin, you lead to several problems. First of all is the fact that taking a little skin away, you don't get much result because they have underlying pseudotosis where their eyelids are such small apertures that have only gotten worse with aging. You take a little skin away, you haven't fixed their pseudotosis, their eyelids look still small, they feel like you've done nothing for them, and you have. Then you said, well, okay, well, I just go postceptorally, take a little fat out, debulk some of the pseudotosis in terms of the fat. But then if you don't create a fixation and you go postceptorally, what I've found in my hands is that you get variable fixation of the levator, and then you get this weird looking, this doesn't work. You either have to go all in or don't do it at all. So my suggestion of someone that really has almost an absent fold is don't take away skin. Don't treat it like a Western person where you're going to take away skin. You have really two options here. Doing a formal Asian blepharoplasty or adding volume. Now the two caveats with that is that if you're going to do an Asian blepharoplasty where you're removing skin and you're doing the fixation suture I alluded to and I talked about in the first half of this lecture, and you're good at this, the patient needs to know the protractor recovery because a lot of people that are 20 years old can deal with it, but if they need to know that they're not going to look natural for a few weeks to a month, they need to know that. And for women, it's easier because they can put makeup on to cover it, put some eyeshadow on. For men, and for women, I tell all of them, buy a pair, even if you don't wear glasses, buy a thick black frame glasses that are low and rectangular. Wear that in the postoperative setting so that it covers and masks that, especially for men that can't put makeup on. And I actually tell them, even if it's a fake pair of glasses, start wearing that pair of glasses leading into the surgery on an intermittent basis. That way, someone won't figure out that, hey, you just had the procedure done. It'll sort of distract them. So you have to warn the patients about the protractor recovery. If it's fat grafting or fillers, the real problem is that with this degree of pseudotosis, oftentimes when you add fat in there, they may not get too much of a result because their eyelids are very, very small to begin with. So, and you got to be careful not filling so much that you actually worsen the pseudotosis and make them narrower. So a lot of education before you do it, and being very careful during the injection process not to overdo it, and maybe doing fillers if you're not comfortable with fat where you can't reverse it. So hopefully that subtlety is there. Example of a 40-some-year-old Vietnamese woman, I just put fat grafting in. This is right at the margin of where I could possibly take skin away. This is a Chinese woman where I took skin away. She has a crease ready there. Took some skin away, added fat grafting there. And that's just a traditional Western skin-only blepharoplasty, no fixation whatsoever. This is a lady where it looks like she probably needs a blepharoplasty, but I just did fat grafting around her eyes, and that was enough to excavate that hollowness that was there and really cover that orbital rim exposure. And, sorry, this Advancer is slow. And this is a lady this is very typical what you're seeing nowadays. A lot of Asians say, you know, I'm getting all these folds showing up as I get older, and the reason is that involution of volume. So this is just adding some hyaluronic acid, this Restylane, what it does is it redefines that crease. So this is a non-surgical outcome. But if you have this multiple crease and fold, you don't necessarily have to go and do a fancy Asian eyelid procedure or even a fat graft or anything else. You just add a little bit of filler there, and blam, you get this very durable result where it fixes these multiple fold issue. And we're almost done here. Textbook, I have no royalties for any courses I run or any books. Everything goes to charity. Plus, I honestly don't buy this book. It's too outdated. There are a lot better books out today. This is written in the dawn of the history. I don't even know if they print it anymore. Just want to show it that I wrote a book, that's all. So I always encourage all of you, the passion that I have is artistry. It's so fun. So think creatively, and every time you think creative, you'll get better, and and every time I teach, I think better. And thinking is so important, and looking at the world in artistic fashion is critical. As you guys know, I do a lot of hair restoration. I really encourage you guys to come to my hands-on workshop in mid-November. About 5 minutes early. Should I field a question? If there's any questions, I'll field the question. But
we have 5 minutes if anybody has any questions.
Yes?
What is the trick to finding the muscle?
The levator? The trick is finding the fat. And if you find the fat, you're safe. If you can't find the fat, you don't know where the hell you are. So I have to find the fat. And so the way to find the fat, as I alluded to earlier, was to blot so that I can actually see where it wants to poke out. And for me, where the most exuberant part of the fat is about 2/3 laterally on the incision and toward the inferior aspect. I just have my staff 4 fingers, and if they sometimes can't find it, what I do is, where the trick is, when if someone's inexperienced, just stick 4 fingers down, it's not right, because most of the fat is coming from superiorly. So I want their upper 2 fingers to be pushing down. I'll show them. I'll say, look, push the fat this way so that I can see it come up. Then I just tease and make a small incision through there. Now, as I warned you, if you're dealing with someone 45, 55, 65, they oftentimes have extremely little postseptal fat, because that's the reason you add fat. So what I'll do is, if I blot and I say there's nothing blotting out of there, I'll make a small fenestration, okay, and then I will tease it up with mosquitoes, and I will look for the fat underneath. Otherwise, you can violate the levator by just inadvertently cutting down. Brian?
Sam, I think your comments are exactly dead on. We do see, not infrequently in older patients, and even sometimes in their 40s,
Yeah.
involutional changes to the levator where there's fatty infiltration, and if you don't know for sure that you've got preseptal, pre-aponeurotic fat, you can actually go right to the levator. Next thing you know, you got full fetulous defect in the levator.
Yeah. Yeah, so you got to sort of mentally treat a 20-year-old different from a 45. Anyone over 35, I don't know, would you agree? At 30-something, I start treating differently. It's very easy on a young person. They all have exuberant fat. But I encourage you, because if you do enough 20-year-olds and you do enough 50-year-olds and you see, oh, all the fat goes away. I personally think, unless the fat is obstructing your levator adhesion, think about it. You're doing a disservice to the patient. You're accelerating their aging process. Yes?
There's